laptop. Is that okay?
Yeah, let me just.
Can you guys hear on Zoom?
Yeah, yep, they're good. Thank you.
All right. Sounds good. Thank you for the invitation, Desmond. I'm very happy to be here today. So I looked at the MindCORE description, and what it recommended for speakers was actually to talk kind of big picture about their own research and how it relates to other disciplines. So I took full advantage of the opportunity to zoom out a little bit and talk about my research program and how I'm thinking about it in terms of a broader framework. So I get to try out some new material for you guys today. I'll find out if it's any good by your reactions and go from there. But I did want to take the first like 5 slides or so to just kind of give you a version of the main thrust of the lab. So I'll do that now. And the thing that we're really interested in developing is a clinical tool for personalized stroke outcome prediction based on lesion location. So what that would look like in my vision is, if you have a woman who comes into the emergency room with new onset trouble speaking and right hand clumsiness, goes off to the MRI suite and has an MRI showing a stroke. There are a lot of questions naturally that happen over the inpatient hospital stay. And what does the future hold for this woman? Is her speech going to come back? Is she going to regain use of that right hand? Should she continue working? Is this going to be disabling to the point where she can't work? A lot of open questions, and currently the way that we're handling those questions in neurology is just based on the clinician's judgment and experience with prior cases. And wouldn't it be great if we had some empirical data to guide outcomes? So we all know in neurology that lesion location matters a lot in terms of determining how somebody's going to do after a stroke. And the goal would be to leverage that and create a clinical tool based on that. So we have decades of research doing lesion symptom mapping studies. So the gist of that is you might have a cohort of individuals who have some behavioral syndrome of interest after a focal brain lesion, or some, any behavioral assessment could be done. You have a comparison group that also has that same behavioral assessment. Maybe they're not impaired, or maybe they're less impaired. Everybody has imaging of their brain to define a lesion location. Everybody has behavioral testing. It could come from neuropsychological assessments, or it could come from just the patient report. There's any number of things that you could measure using this approach. And then you have some statistical package to ascribe a lesion symptom map. So to essentially identify the region with the strongest association with deficits. So this is something that's been used for decades. There are varying levels of sophistication in terms of the statistical packages that you can use to do this kind of work. The one that we favor actually, I think, came from Penn, which is sparse canonical correlations, multivariate lesion symptom mapping. And the idea is that if somebody has a new onset stroke, you could have automated ways to detect where the stroke location is, which is a topic that we're very actively working on right now with colleagues in engineering. Then you would move that location into an MNI template brain, where we have lesion symptom maps that exist from hundreds or even thousands of individuals, showing these regional findings that are associated with the deficits across different domains. So whether that's expressive speech or receptive speech, or motor deficits, or working memory deficits, or mood, anything that you can imagine that you could map across hundreds of participants, you can create these lesion symptom maps. And then you can create a profile of risk for an individual patient, and then have like a text-based output that would help with the clinicians who are managing the patient. So that's sort of a broad goal of the lab, and something that we've been working on for a few years, and no doubt we'll continue to work on it for several years. I'm at a really fortunate institution for this kind of research at the University of Iowa, because they've been a site for doing lesion research for decades. So starting with Arthur Benton in the 1950s, Antonio and Hanna Damasio moved to Iowa in the late 1970s, and they really developed the Iowa Registry as we know it today, which includes individuals with focal acquired brain lesions who are developing normally up until the onset of that lesion, and then they get really well characterized in terms of cognitive assessments, mood assessment, personality assessments, everything that you can imagine. We try to be very comprehensive in our testing, and then that data exists for these types of lesion symptom maps. And my hope since moving to Iowa is to leverage this large database in a clinically useful way, which is kind of what I was talking about earlier. All right, so I'm not going to talk about that. This is the last slide on that topic, but if you're interested in that topic and disappointed that I'm not covering it today, this is pretty good status of where we're at. This is a Brain article from Mark Bowron, just came out a few months ago. And you'll see that we're using not only the lesion location, which I talked about from that lesion symptom mapping, but we're also trying to integrate human connectome data and take advantage of normative connectivity patterns. So things like tractography and resting state functional connectivity, and see if we can augment our predictions using that kind of information. And we've had some success showing that you can predict even more variants than would be allowed from the lesion symptom maps alone with integrating human connectome data. And then we supported that through validation in a secondary cohort that was from Washington University. So that's probably the best summary of where we're at right now with that work. Now I'm going to switch gears and talk about something totally different. And I'll start here with this figure, which I think is a really nice display of behavioral states. So I came across this figure, I think more than a decade ago now. It was in a book that I was reading. And all I really mean to highlight here is that there are different states of rodent behavior in this case, but the same is true for humans, where you have major states like slow wave sleep, REM sleep, quiet wakefulness, or whisker twitching, which is meant to be active engagement. And this was from Beyond Boundaries. And I think the reason I like this figure is it shows that behavioral states are really well organized. And I think this is a nice starting point when you think about the complexity that is rodent behavior or human behavior. It's nice to think about it in terms of categories, and that's a good, simple starting point. The peaks are just time spent in these individual states. So like the higher the peak is, the more time in that state. And I think the nice thing about it is just that, you know, you're essentially showing that it's not just a morass of different behaviors across the day. It really kind of aligns into discrete states. So that's the only point that I'm making there. And those discrete states are going to be supported by different anatomical underpinnings, different physiology, different chemical milieu, and obviously different experiential states as well, different mind states. So the subjective experience that you have when you're in REM sleep and dreaming, for example, where you might start randomly flying or things like that, you know, crazy things can happen, bizarre things can happen that would never be okay in the wakeful state. Whereas in slow wave sleep, you have a relative paucity of content in terms of the things that are coming to mind. So we have those same states in humans, obviously, in all mammals, and wake, sleep, REM, most broadly speaking. Then I think you can have another useful, a little more granularity in terms of being awake and being engaged, and the thing that you're, you know, so engagement with something in the environment versus mind wandering. And the direction that we're going with this is to talk about these brain states as they relate to mood. So just to foreshadow that. And then within the category of mind wandering, you can really be in a state of opportunity seeking versus threat assessment. So those aren't the only two things that can happen while you're mind wandering, but I think those are two useful distinctions. And then naturally, people have spent a lot of time characterizing the approximate amount of time that people spend in these different states. And surprisingly, mind wandering is about half of our wakeful life. We're thinking about things that are not actively, you know, in the environment around us. So very quickly, you know, when you're awake and you're engaged with something, you're often performing some attention demanding task. Your mind is often very attuned to specific aspects of the environment, but effectively ignoring a lot of other aspects of the environment. So if you're in a athletic competition, you might be totally oblivious to the fact that there are thousands of fans screaming at you, but very, very sensitively attuned to, you know, the smallest movements of your opponent. It's a very immersive experience and has obvious survival advantages. And then if you think about that in terms of the neural systems that support that, I think you're going to have a relatively higher amount of monoamines relative to other states that I mentioned. It's really going to be supported by sensor motor systems, visual, dorsal attention, frontal parietal, with a relative reduction in the default mode network activity. Versus mind wandering, very different, where you're often resting or doing some non-demanding task. And here you're going to have much more activity in your default mode network, relatively lower monoamine tone, and a relative reduction in those same test positive networks that I just mentioned in terms of engagement. So the neuroanatomical substrates that support this, this sort of dichotomy between engaged versus mind wandering states are kind of on two ends of an anatomical gradient. There's nice work showing that these default mode nodes are actually really specifically located in regions that are as far away as you can get from the primary sensory cortices. So if you think of primary sensory cortices as things that are critical for, monitoring your environment in real time, then the default mode is as far away from that as you can get, whether you are considering distance in terms of connectivity metrics or actual physical distance. And then the increased granularity here in terms of, you've got default mode network as sort of the core, I think of, in terms of mind wandering states, but then there's also going to be input from things like the nucleus accumbens and approach related neurosystems when you're in a more opportunity seeking state versus when you're in a more threat assessment kind of state. You're going to have a relative greater input from structures like subgenuine anterior cingulate, amygdala, fed nucleus, or the stria terminalis. And I think the subjective experience that would be associated with this would be things like rumination, worry, brooding. And obviously it has its advantages in terms of identifying threats, potential threats, simulating how you might respond to those different things. And it would be, of course, ridiculous to anthropomorphize these brain regions too much or ascribe cartoon characters to them, but that's what I did anyways here, just in terms of like thinking about how these different neural systems are contributing to the conversations that you're having inside of your own mind. I think that these different areas are contributing more threat assessment kinds of content versus opportunity seeking. If any of you guys watch Inside Out, got 2 kids, so do that frequently. So this is where we're at here, just in terms of a broad background about these brain states. And I think that brain health is really a situation where we're specifically engaging in these different brain states according to the environmental contingencies where it's adaptive. So you'd be capable of full immersion into a state, not having intrusions from other states that are unwanted, flexibly switching as the environment changes, and having crisp transitions without a lot of intrusion is a key point. So this topic is something that I think a lot about in terms of clean transitions between states and avoiding intermediate states. And there have to have evolved mechanisms to keep them distinct, right? And I think it's interesting to think about what neural systems do that for us. And it's probably most well studied in sleep versus wake. So 2 very broad states that have been studied extensively. And naturally, from an evolutionary standpoint, you don't want to be in an intermediate state ever, right? It's not going to be, you don't garner the advantages of being awake. You don't garner the advantages, the rejuvenative properties of sleep. So you want to be in one versus the other, but not both. And the way that that is implemented in terms of neural circuitry has been really well worked out, dating back to work by Von Economo. Wally Nada was an MIT neuroscientist who did some of the first work on the hypothalamus in rodents, and then Cliff Saper is really actively involved in this today. He's the chair of neurology at Beth Israel. And the system that seems to be most critical for this is a sleep promoting region of the anterior hypothalamus and a wake promoting region of the posterior hypothalamus. And I think of those 2 as essentially antagonistic to each other. They're inhibiting each other, which is shown here. They have direct projections. One inhibits the other one. And that battle line is essentially what determines whether you're awake or not. So you've got this arousal promoting system, and when it's effectively shut down by the sleep promoting system, then you can sleep, and vice versa is true as well. And David Fisher isn't here today, but I wanted to give a shout out to his work on the helping to work out the wake promoting aspects of the arousal system in humans. So he and I worked on a lesion study together when he was still a medical student at Harvard. He's a faculty member here in neurology as of a few months ago. I think he's in Texas today. But he helped identify the brainstem region most critical for arousal by identifying individuals who had focal brain lesions who developed coma relative to a cohort that had focal brain lesions that did not develop coma. And that was the dorsolateral pontine tegmentum. And then obviously there's going to be a lot of different factors that can modulate this competition between these two regions: caffeine, medications, lighting, all kinds of different things that you can imagine. And then one other thing from our own work that I wanted to highlight is, interestingly, these two regions defined anatomically: the posterior hypothalamus, the region that's most wake promoting, versus this anterior hypothalamic region that's most sleep promoting. We had Cliff Staper identify these sites on an MNI brain when I was a research fellow, and we did a connectivity analysis with human connectome data and showed that, interestingly, they have entire brain-wide networks associated with them, and they're very much anti-correlated in the same way that the default mode network and these task-positive networks are anti-correlated. So distinct brain states, competitive in terms of how they're competing for state space, and anti-correlated networks. So far, very basically, we've talked about different brain states existing, supporting by different macroscopic brain regions. There are circuits that compete to uphold these different brain states, and the example that I talked about was sleep-wake. And then a final point that I want to talk about that's a little bit different is that I don't think of these as completely separate brain systems. I think there's a lot of neural substrate that's shared between mind wandering versus engagement. So the way that I kind of imagine that happening is if you have different broad constructs that your brain has to be attuned to, like monitoring the physiological state of your body, monitoring what's happening in the real world, moving around in the real world. I think that you can think of that in terms of having real maps that actually reflect what's truly happening in real time. And then you have higher order association regions in the brain that are consciously accessible, that are a reflection of that. And then you have the highest order regions that aren't necessarily contributing to conscious images, but are helpful in generating them in terms of internal models or imagery, essentially. And I think that the image space that we're conscious of, which is represented in green here, can kind of flexibly transition between more reality focused versus more heteromodal, higher order image-based processing. So what I think of in terms of a helpful way to convey that is this green image space that we're conscious of when we're engaged in a task, swinging out more towards real world input. And then when we're disengaged, swinging in and having more influence from higher order structures like the default mode. So where I wanted to get with all this was this interesting topic of what determines when we're engaged versus mind wandering. I think that has a lot of relevance for mood, and that's kind of captured my interest recently from study results that I'll show you. So I think that competition, it must be as old as the central nervous system processing is, I think. So in my mind, probably what's most critical in making those assessments and what has primacy is probably really basic circuitry related to homeostasis at the most basic level. And then I think the more evolutionary modern instantiations of that circuitry would be things like the central autonomic network and the salience network that are going to be really critical for deciding at any given time across different environmental demands, which should be the focus of attention, whether or not you should be engaged in the things in the immediate environment versus mind wandering would be okay. And I think in terms of the cortical influence of those regions, I think some of the nice early work on this was Drs. Menon and Uden. So they have some nice papers that are worth reading about on this topic, and they really focus on the anterior insula and its role for broad network transitions going away from the default mode and towards a task positive engagement with the environment. So this last point here is that I think this balance of wakeful states engaged versus mind wandering has a lot of relevance for mood. One study that showed that is the Science article showing a wandering mind is an unhappy mind. And this got a lot of press, several years old now, but they showed that about 50% of human time is spent mind wandering. And when we're mind wandering, we have significantly lower ratings of happiness than when we're actually engaged in a task. So that's reflected down on this bottom part here, where you've got the x-axis with happiness ratings, and not mind wandering is associated with the highest ratings. Doesn't matter what you're doing. You can be doing an unpleasant task, but as long as you're engaged in it, you're more likely to be happy relative to when you're mind wandering. You can be mind wandering even while you're engaged in a very enjoyable task or something that you'd label as enjoyable, but be less happy. So neutral mind wandering, unpleasant mind wandering, those are the things that are really most associated with unhappiness. And in that context, I think it's interesting to think about mood disorders. Like, one element of mood disorders having an imbalance amongst these different states, where you're spending less time engaged with the local environment and more time mind wandering. And I think there's a preferential activity that's happening in terms of the threat assessment part of mind wandering. And if you look at that concept relative to the depression literature, it really fits a lot of different findings from different methodologies. So things like the default mode network being hyper-connected relative to the task positive network in the setting of major depression. You can think of the loss of default mode network versus task positive network anti-correlation as an impaired antagonism between those two broad networks. And then I think, there's a lot more threat processing, rumination, brooding relative to opportunity seeking in terms of the subjective experience that happens when mind wandering in the setting of major depression. And you can imagine those as more influenced from regions like the subgenuine anterior cingulate, the amygdala, relatively higher glutamate tone. And then another finding that seems to be relatively consistent is the subgenuine anterior cingulate tends to be functionally connected with the default mode network to a greater extent in the setting of major depression. And that often normalizes less subgenual input into the default mode network with effective treatment. So kind of going back to the influence that these different individual brain regions and neural systems can contribute to the content of mind wandering. So that's all background that I think is relevant in how I'm thinking about some of the latest findings that we've had in the lab that I'll talk about now. So interpreting symptoms of brain lesions in light of this brain state framework. So the first one is an old finding, and that is asking the question, are there brain regions that when lesioned would reduce mind wandering, as you might expect? If that's supported primarily by the default mode network, you could have the hypothesis that lesions of the default mode network are going to preferentially reduce mind wandering. And that's basically exactly what graduate student of Dan Trinell's, Carissa Filippi, found. She's a faculty member now at St. Louis University. But if you have focal brain lesions that involve the medial prefrontal cortex, was the site of maximum overlap for this study, you have a reduction in mind wandering. So naturally, you'd have a greater percentage of time engaged with the environment. That was that paper title. She also did lesion network mapping and showed that the default mode network was the core network associated with those lesions. They could actually be in other areas of the brain, not just medial prefrontal cortex. So we saw inferior parietal, for example, but in a site that was overlapping with the default mode network. So I don't think that's shocking. That would be kind of expected, but it's a nice demonstration of lesions having a causal influence on these different networks and having a manifestation in terms of how people subjectively report mind wandering. And then I think the same sort of framework is useful in thinking about our most recent results, which is a study by Nick Trapp that was just published a few weeks ago in Brain. And this has been a long-standing process. Justin was in the lab a couple of years ago, and it's been going on for probably 4 years, probably 2 years before he got there. So a long-standing study of looking at depressed mood in individuals with acquired focal brain lesions, 526 participants. We had subjects from both Iowa as well as a Vietnam cohort from Jordan Grafman that we combined into a single study. And I just have one main data slide to show here, but I think it captures the main findings, which is that there are some regions of the brain shown in the warm colors here. So the red, yellow are regions that, when lesioned, are associated with higher levels of depression. And there are regions in blue that are associated with a relative lack of depression. And not just a lack of depression, it's actually lower levels of depression than you would see in the normal healthy population for age-matched published norm data. So it's not just that they're avoiding the harmful effects of focal brain lesions by not hitting these regions that are associated with greater levels of depression, they're actually reducing their levels of depression. And this is a overall relatively weak finding, which is why we needed to include Jordan Grafman's data to get a significant result. The R value for this is 0.11, which for most lesion symptom mapping studies for aphasia or something like that, we're talking about more like 0.6. So I think it's not surprising that this has been notoriously challenging to map in terms of lesion symptom mapping. People have been doing it for decades, and there's a lot of controversy. Some people will find findings in the left dorsolateral prefrontal cortex, and then another group will say, well, actually, that's not right. There's no findings in the left dorsolateral prefrontal cortex, and it's kind of gone on and on like that for decades. And I think the reason is that it's really unreliable with sample sizes that are smaller than 300 subjects or something like that. So you really need huge data sets to try to tease out significant findings. But the thing that I think is really interesting and sort of unexpected about these findings is that the strongest finding of anywhere in the brain is that right anterior insula, which, if you go back to the story about salience network and transitioning between these states, that's like the key hub for that process. And if you look at the regions that are associated with a lack of depression, it's the core nodes of the default mode network. It's not subtle at all. Like there's a big default mode network node here, and in the anterior temporal lobe, and then the medial prefrontal cortex as well. So it sort of fits if you think about mind wandering being a risk factor for lower mood, which is shown really crystal clear, I feel like, from the Science article, but has been replicated in other studies here. And then lesions to the default mode network are associated with reduced mind wandering and also improvements in mood. So we haven't looked at that in the same subjects yet. The subjects that we looked at mind wandering, we haven't yet looked at mood in. We'll plan to do that. But that's kind of a framework where I think these findings make sense. Like at first blush, I feel like you could look at it and if you didn't have the context of specific brain networks in mind, if I would have looked at this, say, in the year 2000, I would have just been like, well, it kind of looks like they're all over in different places, but it actually really closely aligns with the networks that we're discovering from things like resting state functional connectivity. And I think these dorsolateral prefrontal cortex findings that we're seeing could be driven by salience network nodes. There's definitely a node of the salience network in the dorsolateral prefrontal cortex, but it could also just be more generally task positive networks, which exist in the DLPFC. So that is the main data slide. There's a couple of other findings that I can talk about that are in the same vein, really, that kind of fit this underlying model. And one is, it's not published, it's currently under review, but we're asking the question, are amygdala lesions associated with improved mood? With the idea that the amygdala, I'm sure it's an oversimplification, but thinking of the amygdala as a region that is involved in systems that are important for thinking about threats. So amygdala is important for processing fear, anxiety, certainly highly implicated in depression. I think one of the nice causal findings recently was from the UCSF group, Scangos et al. In Nature Medicine. They showed that gamma power within the amygdala is correlated with depression severity. And then when they electrically stimulate and reduce that gamma power within the amygdala, is associated with a robust mood improvement. So I found that to be compelling evidence. It's less clear what the effect of lesions on mood are. So that was the question that we wanted to approach here. And we have access to individuals who've had medial temporal lobe surgeries where the resection of the amygdala is variable. So some individuals will have full resection of the amygdala, some will have the amygdala retained. And we took advantage of that variance in terms of amygdala resection to ask the question of whether the amygdala inclusion in the lesion resection cavity had any influence on mood, basically. So there were 43 subjects that met all our inclusion and exclusion criteria. So they all had a medial temporal lobe surgery. They all had a post-surgery MRI in the chronic stage. So usually 3 months or more after the surgery. So there's no longer edema and things like that. We excluded anybody who had continued to have seizures because we didn't want the effect of seizures to impact their mood. I think it's reasonable to think that if you had a major brain surgery where part of your brain was removed to stop seizures and you continue to have seizures, that would be a depressing thing. So it could be a real confound for this kind of study. So everybody had exclusively good outcomes. We allowed seizures only if it was like a single instance and could be explained by other things, like they forgot to take their medicines for a few days or something like that. And they all had BDI measured pre and post surgery. So our hypothesis was partially supported in that we did a multivariate lesion symptom mapping of all 43 of those individuals. And the right amygdala showed up as the key site that was associated with a lack of depression or a relative higher mood, which fits that overall story, I think. Interestingly, the overall BDI scores improved. Maybe that's expected given that their surgery was successful, but it was variable. So 27 improved, 16 worsened. And then there were some small findings that were in the opposite direction. So this amygdala finding was associated with a lack of depression. There was sites in the hippocampus and parahippocampal gyrus that were associated with higher levels of depression. And then could depression treatments be interpreted in light of the same brain state imbalance that I think can be useful to think about in terms of the lesion studies. And here I'll mention what Desmond was talking about briefly, that we do TMS studies as well in my lab. And one of the main areas of focus is actually doing TMS in neurosurgical patients who have intracranial electrocorticography monitoring. And the idea there is that it's still very much a black box in terms of how TMS is influencing the brain. We use it to treat depression. So it's a very common thing that we do. We probably treat 10 or 15 patients every day of the week, Monday through Friday, targeting their left dorsolateral prefrontal cortex. But there are a lot of open questions. It's effective, but only for about half the patients or so on average. And there are potentially things that we could do to make it much more effective, like if we knew where to target in the brain. That could be a potentially huge thing. I know that's a big focus of Desmond's lab as well. And one of the things that I'm most interested in is the deep effects of TMS, because I think a lot of the most critical circuitry related to mood is actually happening deep in the brain, not necessarily in the superficial cerebral cortex. So can we anticipate which deep structures are being modulated based on resting state functional connectivity MRI, and then show that using ECOG. So that's kind of the setup for the study that we've been doing now for about 5 years. And this is what it looks like. So the most common site that we're stimulating, we have a few different areas of interest, but the most common site is the left dorsolateral prefrontal cortex, the same area that we're stimulating for treating depression clinically. And just one result slide for that analysis. This was in conjunction with Corey Keller's lab, who's doing the intracranial electrophysiology work here. But the highest proportion of significant responses to left dorsolateral prefrontal cortex stimulation is in the anterior cingulate, sort of extending up into the pre-SMA region, which is a major node of the salience network. And then also findings were present in the anterior insula. So I think we're hitting that same salience network that showed up on the lesion study as well when we're treating patients with depression. Whether we are aware of that or not, I think that tends to be the neural system that gets affected. And here I just want to acknowledge that slide was possible from a whole team effort. So I don't do intracranial electrophysiology, so we've been relying heavily on Corey Keller and Jeff Wong, who've done a lot of the work for that. And then I think more broadly speaking than that even, a lot of the cognitive tools that exist for depression are also sort of along the same lines. There's a lot of cognitive behavioral therapy, for example, that recommends people challenge their rumination and see if it's really legitimate or unnecessary, or other lines of therapy that really focus on living in the moment and mindfulness and things like that. So I think it fits with a lot of existing literature. It's nothing new, but I think it's a helpful framework for thinking about some of these findings. For me, it has been anyways. And then going all the way back to our first patient who presented to the emergency room with some difficulty speaking and some right hand clumsiness. So this is a woman that I actually met with a couple of weeks ago and asked her how things were going. She had a really severe aphasia at the time of the stroke. I saw her about 4 months later when she was participating in a research study, and I just stopped in to say hello, see how things were going. And she said that it's been really challenging in terms of the rehabilitation, but her speech is actually much, much better. She's able to hold a conversation, so that was promising. And asked her how her mood was, and she said that it has been exceptionally challenging. Life has been exceptionally challenging since the onset of the stroke, where she really just feels like she struggles to have the desire to even stay alive. She feels like she continues living for those people around her that are important, but she's sort of lost the motivation to live, and it's not something that she was comfortable talking with. She was in her 60s and had spent her entire life without any psychiatric problems at all. And I told her about this study of Nick's that was just published, and that this lesion location was actually really one of the core areas that were most associated with depressed mood. And that was, for her, deeply meaningful to hear that, because she had spent the last 4 months thinking that she was crazy and was reluctant to seek treatment because I think maybe there was some stigma associated with seeking treatment for depression. So I think that's one of the examples of, I think, just providing patients with information about what to expect can be really meaningful, even if that was just a sheet of paper and if it was somewhere on there that this is a stroke location that has been associated with depression. If you're experiencing depression, you should talk to your physician as soon as possible. I think she wouldn't have had to suffer as much as she did for those 4 months, and she would have sought out treatment earlier. So that's kind of circling back to the idea of lesion location, and personalized outcomes, and the potential clinical importance of that topic. So that's all I've got. Have a lot of people to thank, a lot of great mentors along the way, a lot of great people in my lab that are fun to work with. Had to pull out a picture with Justin still on there for that one. I would be happy to take questions from anyone as well. Yeah.
Okay, this is my code. So I studied kids who are happy. It's a terrible network, right? And then we get very unhappy stimulation and happy again as our network stops. How do you resolve those developmental trends with this idea?
Yeah, it's a great question. So developmentally, I guess I have not gone into great depth thinking about this, but one thing that I will say is that kids, relative to adults, don't do a lot of being totally mind wandering about rumination and things like that. In my experience, they're much more engaged in the environment. They're a little bit more like my dog in that sense, like they need constant stimulation from what's around them, and they would have a really hard time sitting for 3 hours and thinking about things in a way that adults wouldn't. And I think that changes over the course of adolescence, and I think that's around when you see a huge spike in depression. Whether or not those two are one-to-one causal relationships, I don't know, but I think that but we're relatively protected, at least at a population level, during childhood for symptoms of depression, and then the onset really spikes in adolescence, and that's around the time when people start spending more time disengaged from the environment and start spending more time ruminating about various things that might be concerns. So that's how I think about it. And then in terms on the other end of that spectrum with older age, have not thought about it at all, but default mode network regions tend to atrophy over time.
Sure.
Yeah, it's a great question. I mean, I think the distractions from your phone, for example, buzzing or things like that, or yeah, I mean, in my mind, I guess the optimal way to handle those is going to depend on what you're needing to do. So if you're engaged in some task that's important, you need effective ways to tune all of that out. And I think that's something that people with good cognitive control have. And I think that's something that people with severe depression often lack, is just the ability to tune everything else out. But I don't think that's always important. I think that, I guess the point that I would make is that it probably matters a lot what you're actually doing, because I think it's advantageous to be attuned to the environment most of the time, but then certainly there are times where it's advantageous to be tuning everything out of the environment. And I think doing it in a way that's adaptive and not a way that is constantly feeling like an intrusion. And I feel like that's probably a cognitive control based mechanism that varies a lot interindividually in terms of how effective people are at it. Yeah.
If you were to target for an intervention, based on your data or just some hypotheses you have, do you think that shifting people out of mind wandering, focusing on the environment would be more critical, or do you think it would be maybe you assume that you can't do that very effectively, and people are going through a lot of mind wandering, so you would shift them just having more of a positive basis?
Yeah, it's a good question. I mean, I feel like if you think about this in terms of different targets for intervention for things like deep brain stimulation and TMS, I think you could certainly imagine that tamping down the threat assessment is going to be effective. And I think that the lesions of the amygdala would support that. I didn't present it today, but we also have a recent unpublished result from the sagittal anterior cingulate that it was an area that popped out of a whole brain analysis for reduced anxiety. So I think that trying to inhibit the influence of those areas is going to be effective. But I also think that what we might be doing is augmenting plasticity mechanisms in the salience network to help recalibrate the balance between these two. So in my mind, I guess for TMS targets, my working model, and I don't feel strongly about it, but the way that I think about it is I really like the work where they're trying to evaluate whether or not cardiac gated MRIs or cardiac gated targeting is effective, where you really highlight a site in the dorsolateral prefrontal cortex that engages the autonomic nervous system, demonstrated by things like changes in heart rate, as a clue that you're in a portal that's probably part of the salience network. But I don't feel tied to that. I feel like it's very much an open question, and I would readily embrace other targets just as easily. I feel like it's a wide open question, but my leading intuition right now is that salience node of the DLPFC is probably the best target if I had to pick one.
Great talk. Thank you so much. Looking at your model, one question I had, you sort of portrayed opportunity seeking and threat assessment under this category of mind wandering, and there's value towards pushing the seesaw towards engagement.
Right.
And one thing I'm having a difficult time sort of situating in your model is the idea that there are neural systems for opportunity seeking and threat assessment with respect to the engaged external as well, and you see deficits in engagement with respect to threat and opportunity and amygdala and all right? So like, how does that fit?
Yeah, it's a great question. And it's something that I've thought about as well. Like, so obviously opportunity seeking and threat assessment are even more important in the engage because threat assessment, when you're awake and attending to the environment, it could be the difference between life and death, right? Like if you have a car speeding towards you. But I guess the reason that I didn't emphasize it here is in part just because of time, but in part because I don't think that the high threat assessment in real time is probably as critical for major depression as what happens when you're mind wandering. Like I feel like people who are severely depressed have a lot of trouble engaging in the environment for a sustained period of time and spend a lot of time with ruminating negative thoughts. So I feel like just in terms of thinking about this in terms of major depression, I feel like what happens in the mind wandering state is relatively more important. But I don't think that that's more important in terms of how these systems evolved and how I would think about them outside of that context of mood. Does that make sense?
So thanks for the talk. I'm somewhat concerned about this rigid distinction between engaged and mindful in these states that are proposed to be
Yeah.
strictly like
Yeah, yeah.
So it's hard to think of any human behavior as being pigeonholed. So
I would agree with that. So the question is, the concern is that these are presented as two distinct things, and it can't be the case, right? They have to partially overlap, and we're constantly flexibly going between the two. So I think it's an artificial separation, but it's an artificial separation that's useful potentially, to me anyways, in thinking about it, because I think that for sure there are mind wandering thoughts that happen during almost any activity, other than maybe the most pure examples of this. If you're fully engaged in a flow-like state of doing something that demands 100% of your attention, you're probably going to have very, very little mind wandering. But I agree with you that it would be probably more accurate to present these as two normal distributions that overlap in the middle quite a bit. You can actually get a sense of that to some extent from that Science article, if I find it. In terms of all the different things that people do and how often they're spending in mind wandering. So it's not on this slide specifically, but it varies a lot from activity to activity. Other than making love is a time when people spend very little time mind wandering. So, but I agree with you that it is artificial to treat them as two distinct things that don't overlap. They definitely overlap. Yeah.
So your amygdala, can you tell us if you elaborate?
Yeah, I mean, so we entered all the lesions in terms of the structural MRI resection cavity. And this is just what came out of that analysis in a fully data-driven way. We had a hypothesis that it was really the most medial corner of the amygdala. So that's all I can say, is that that's where the peak finding was associated with alleviation of depression, or probably more accurately to say improved mood. But I don't know if I would feel 100% confident in localization within the amygdala, just given the granularity of these lesions. There are gross resections, some completely wipe out the amygdala, some don't. I wouldn't bet on, if we had another sample that had, instead of 42 subjects or whatever we had, 300 subjects, I wouldn't put any money on it, reproducing to this exact spot. But I find the amygdala finding overall believable, just given what we know about the amygdala.
Okay, so I had a related question. With, the other data slide that you showed, where you were talking about like a lot of like the really in the right football. How much do you think that's about like how depression is in the brain, and how much do you think it's about like looking at self or like some other
Yeah, that's a great question. So for the people on Zoom, it's a question of why do you need 500 plus subjects to get a significant lesion symptom mapping for depression? And I think one of the things that's probably, I think there are probably multiple factors at play, but one is that we didn't know what their level of depressed mood was prior to the onset of the lesion. So all that inter-individual variation that we know exists was essentially noise within that model. And that's noise that is probably hard to overcome, requiring multiple patients. And we didn't select specific lesions to specific sites. I think we could get the results with a smaller sample size, knowing that this map, for example, like if we use that to screen patients and did a prospective study and said everybody who has a lesion that's a direct hit to the findings that were associated with increased depression versus decreased depression, I imagine we had baseline depression levels. I imagine you could get there with a much smaller sample size. And also, I think depression is just a really complex thing to measure. I doubt that there is a neural system for depression, so there are probably a lot of different influences that were not really well set up to tease out. Like one of the hopes for this sample was that we could tease out different clusters of symptoms within the Beck depression inventory and that they would localize differently. And that sort of seems like a natural thing that you might expect to happen, but it didn't happen. Like we had cognitive and affective symptoms versus somatic symptoms, and they looked very similar in terms of the localization. So that might just be the crudeness of the Beck depression inventory. You know, we're talking about just a handful of questions. Yeah, it's a good question though. I mean, I can't say for sure, but those are some of my ideas. All right, we might have exhausted everybody's questions. Oh, we got 27 chats.
With there's no question.
Okay.
My best attempt to capture.
Oh, okay. Oh, thanks. All right. Thanks, everyone.